Last lecture of the morning is about head trauma on anticoagulants. Big problem now because everybody's on anticoagulants, right? Especially the elderly, right? An elderly who falls and bumps their head. And the elderly are the only people who a ground level fall really matters. Not the only people, but pretty much. So this is a big issue. We got a lot of people who are on Coumadin or on aspirin or on clopidogrel or one of the new guys, and they have minor trauma. What do we do about them? So what do you do about them?
Scan them all.
CAT scan them all. Who CAT scans them all? Who doesn't? Who's brave here and wants to say you don't? Okay, good. We got one. I'll raise my hand shyly. Okay, so this chapter talks about that, and I can't say there's a right answer. You just have to figure it out for yourself. And of course, we have outside pressures on us that make us want to do something. But what really happens to those patients? So go back 25 years ago. Some of you were around then. Think about what used to happen when we'd have relatively minor head trauma. So somebody comes with head trauma, they're sick. It's pretty obvious, right? Even before CAT scans, we had some idea what to do, and CAT scans made it really easy. But the person who looked really, really well, what did you do and what did you worry about? So mostly we didn't do CAT scans. GCS 15, even if it was big trauma, we didn't do much of anything, okay? And what was the one thing you had to worry about? What kind of subdural? A chronic subdural. Because if they were in front of you normal, they didn't have a big acute subdural. Now, of course, in the first 5 minutes, they might have an epidural and you had to watch them to make sure they didn't have a sudden deterioration, but that's rare. And those are easy. And usually they're sick by the time they get into you, even with our modern EMS system. So the one who looks well in front of me, the one thing I'm thinking about is, are they going to deteriorate later? And how often did that happen? Very rare. It's very rare, but it happens. So you got to be aware of it because it's really criminal to have somebody who looks great and then you send them home and then something bad happens. Some of those people, by the way, in the old days, there was a great study from in the 70s, I think, or 60s, before there were CT scanners, where they did routine brain autopsies in England in a regular old district general hospital. People who died in the hospital, they autopsied their brains. Most autopsies don't look at the brain. They autopsied their brain, and then they did autopsies of the brain in people who died in the long-term chronic psych hospital next door. And what did they find? They found a lot of the psych hospital patients had a chronic subdural. They weren't psych at all. They had just had a chronic subdural. So that happens, it's real, it's a tragedy. We don't want to miss that. Okay, so that's the sort of needle in the haystack that we got to worry about. The first few articles here, half dozen of them, all say if they look good when they first come, most of these are GCS 14 or 15. I never understand. Some of them 13, 14, or 15. 13 is very different than 15. I have no idea why people lump those together. But in any case, even the 13s and 14s, some of them, when you do a CAT scan, have a little ditzel, but they all do fine. When I say all, I don't mean all. I mean 98, 99, 99%. Very few of them have anything to worry about, deteriorate down the line. So it reminds us that they don't deteriorate, except when they do. We don't want to miss the one that does. Who is most likely to get a chronic subdural, subacute or chronic subdural? Older people. Why?
More space.
There's more space in the brain. That's exactly right. When you bump your head, everybody bleeds a little. Most people tamponade it right away. You don't tamponade it, you continue bleeding, then you get into trouble. Who gets into trouble? People who can't tamponade because they have a lot of space, or people who are on an anticoagulant. Old people are both. So old people are the ones we mostly worry about, also worry about anticoagulants, of course. But again, even in that group, 99% do well. By the way, number 3 says 16% mortality. All the others say just the opposite. So I just want to warn you, I don't know why when this chapter was written, they weren't separated out. All the others are minor trauma GCS 15 or 14 or 15. What happens to them? They do great. Number 3 is people who made it into a major trauma center on the trauma registry with an ICH, 18% of them die when they're on anticoagulants. Those are two incredibly different things. And I don't need to tell you much about what to do when somebody comes in with major trauma and they're on an anticoagulant. I mean, that's not a big, and they have ICH on the CT scan. Okay, we got that, okay? So it's an entirely different thing. Now, the first half dozen articles otherwise say minor trauma, the vast majority do well. And they're broken into two sections. The first is they all do well, except for an occasional one who has a late deterioration. And how late is late, by the way? How long does it take for them to deteriorate? Sometimes. More than 72 hours, sometimes. It could be up to weeks. Chronic subdurals can take up to weeks. So it's not like you could watch them for 72 hours in the hospital and you're done. You're not done. You're never done. You're not done until they die of something else and they didn't have it, because you can get a late subdural, a late clinically important bleeding. So, which is going to lead us to the real critical question, which is what do you do for these people? Okay, so most of them do fine. There's the occasional one who does poorly. Then Articles 4, 5, and 6 say if you get a first CT is normal, they all do great. And therefore, get a first CT, and if it's normal, they all do great. Except one of them says if you get a first CT and it's abnormal, they all do great. What's that called? What did I talk about at day one? Talking about negative predictive value. There are two good reasons why you can have a great negative predictive value. Here's a test. If the test is negative, you do great. There are two good reasons for that. One is the test is really good, and the other is they all do great. So it doesn't matter what the test shows. Now, if your test is not normal, if your initial CT shows a subdural, a little tiny distal subdural, you're a slightly higher chance of having a problem. You go from 0.1% to 1%, but still, they're all going to do fine. So I don't think it helps make a clinical decision. When we get that CT, we're doing it mostly for the patients and for ourselves. The patients feel better. They think they need it. We feel better because it's normal. We feel good. If it's abnormal, what do you do if you have a little distal subdural? You call somebody. What do? They torture the patient a little bit. They watch them maybe, or they stop the anticoagulant. What's the risk of stopping an anticoagulant in somebody who's on it for a standard indication, which is ACS, an old stroke, or AFib? What's the risk if they're not on their anticoagulant? It's like 1% a year is the max. You decrease that in half by putting them on an anticoagulant, which means that if you take them off the anticoagulant for 4 days, 5 days, 6 days, what's the chance they're going to have a problem? Essentially zero. So we could stop the anticoagulant on every one of these patients without a CT, without anything else, give them a few days. If they are oozing in there, have them normalize. Talk to their doctor, make sure you get it okay. But unless they got a pig valve and they're really at high risk for an event, for a VTE event, they can tolerate a few days off their anticoagulants. Now that's really easy to do when you're on Coumadin or aspirin. It's really hard to do when you're on these other drugs. And so we'll get back to that a little bit later. We're going to talk about the new drugs. Anyway, so if you get the CT and it's normal and everybody feels better, you can assure them that they're going to do great. If you get the CT and it's abnormal, you can say, don't worry, you're still going to do great. And if you don't get the CT, you can say, you're going to do great, because they're going to do great. But you also have to say, but we need to do good follow-up, because that's the key, because 1 out of 100, 1 out of 500 will get worse, and in a really important way. So if they have good follow-up, it's easy, right? We make sure they got a good safety net. What do you do if they don't have good follow-up? You could do the CT, but again, it's not going to change anything. They still need good follow-up, whatever the CT says. So you do their best. That's all you can do. You can't put them in the hospital if you can keep them for a week, 2 weeks, a month. What are you going to do? You can't do that. You arrange the best follow-up you can. You give them the best warning you can. I'm not telling you not to do a CT. I'm just asking you to think, probably it really doesn't make that much difference in what we do. It is sort of standard care. Everybody does it. You're on an anticoagulant. If they've got a GCS of 13, by all means do it. I don't care if they're on an anticoagulant. But if or at least if they don't wake up you can be on GCS of 13 because they took a sleeping pill. So I'm not telling you to do it in everybody, but if somebody really is abnormal, that's different. But if they're dead, stone cold normal, the big thing is follow-up. It has nothing to do with imaging. Because right now, when they look great, the imaging is not going to show you anything you're going to do anything about. There's no way that imaging is going to go to neurosurgery right now. The patient's normal in front of you. And that's really what imaging is about, right? Which patient do I have to go to neurosurgery? In this case, we're not doing it for which patient has to go to neurosurgery. We're doing it for which patient do I have to worry about. And you have to worry about all of them, regardless of what the CT shows. Almost the same, regardless of what the CT shows. So I don't think it really makes that much of a difference. That's the meat of this chapter. That's part 1, and part 2 is about the new drugs. So, any thoughts or comments or questions about part 1 before we get to the new drugs, the new oral anticoagulants? Okay, so the new drugs, the apixabans, like apixaban and rivaroxaban, and dabigatran are the 2 new guys. It's funny, clopidogrel's no longer a new guy. It won't even be important once it goes off patent and gets to be cheap. But the new guys, what do we know about them? Well, they're really convenient because you don't have to measure labs. That's their big pitch. They also cost a lot of money. Are they better? There are a few manufacturer studies for all of them which say they're better. But I just got to warn you to be a little skeptical because we heard the same thing about low molecular weight was better, heparin was better than heparin, and every time a new drug comes in, the manufacturer studies say it's better, and then typically it gets to where it's not better, but it's not worse, and it's not inferior, and then it's more convenient, and that's where you end up. So it is more convenient, but it costs a lot of money. Is it better? I don't know. There are 2 studies in there for the apixabans, Zabans, which say it is better. They're both manufacturer sponsored. If you look at them, it's sort of interesting because in one study, warfarin did terribly and the Exaban did a little better. In the other study, warfarin did great, way better than the Exaban in the first study, but the Exaban in that study did a little better yet. So both of them said the Exaban was better, but it really depends upon how well warfarin does. And I just have a thought that I always think about with warfarin. If you wanted to design the world's worst drug, conceptually, what characteristics would it have? Well, you don't actually have to think about it. Just say warfarin. It's the worst drug ever created, right? It interferes with everything. You can't keep it in the therapeutic level. It's a pain in the ass. You have to get monitored all the time. It's not very effective. We've been using it for 60 years. There have been at least 10 new anticoagulants over that period that come and go, and warfarin always ends up winning. How could that be? How is that? So my theory is the reason warfarin is really good is because it doesn't work very well. Seriously. Because if you really think about it, Billy said something on this order the other day, our anticoagulation system, our own intrinsic coagulation system is very, very complex and very, very careful. If you go a little bit too much in either direction, you either bleed or you clot. And a lot of the drugs like factor 7A, which is really good for clotting, kills you because it does too good. And we have lots of drugs that can make you bleed better, that can make you anticoagulated, and they kill you because you bleed. So warfarin's secret is that it doesn't really do that much. It doesn't really interfere all that much, just a little tiny bit, which is a little bit better. It bleeds a little bit less than it clots for certain conditions. So for all of these, they're talking about how do you reverse bleeding on these new guys. So what do you need to know? The new guys, they don't have a reversal agent, unlike warfarin, which sort of does. And they Dabigatran is dialyzable, but the other two aren't because they're protein bound. So there's no good way to reverse them right away. They start bleeding, it's a problem. They are sort of short acting, but it's hard to know what to do. If there's somebody's bleeding a lot and life-threatening bleeding, there's no good way to do it. Well, it turned, people looked at what are the choices that you have. So factor 7, for example, was used for, not just for this stuff, but was used for bleeding in American troops. And they abandoned it after a while, even though it was fabulous. They all stopped bleeding right away, and they all died, because they all had tremendous amounts of clotting. And the same thing is true where it's been studied with trying to use it to reverse these other agents. What about vitamin K? Vitamin K, you know, on the boards, it used to be, the oral boards, there was a question where the critical action was you had to give IV vitamin K for a patient who had Coumadin bleeding. Does that make any sense? How does vitamin K work? How long does it take? It takes a long time, because all it does is allow you to recreate clotting factors. All the clotting factors that have been destroyed by the Coumadin, you get to rebuild. It takes days for that to get the ones you need. So giving it IV versus PO is no different. The standard was, of course, fresh frozen plasma. It turns out fresh frozen plasma takes hours. And it doesn't work all that well, which may be why it's not so bad. So what are the other choices? So factor 7 came along, and that doesn't look like it's any good. The new guy is the prothrombin complex concentrate, which is super expensive, but would be worth it if it was really important. There are no real human studies which tell us. There are studies of surrogate markers, how well they fix your clotting parameters, but nothing about human beings. So it might be good, but I wouldn't bet on it. My bet, if I have bet a nickel, is that it's too good, and it'll end up doing the same thing that factor 7 does. But we don't have enough information for me to say that. I don't know, maybe I'm wrong. Maybe it does work. But the homeostasis of coagulation is really, really finely tuned, and when we mess with it, we cause problems. That's pretty obvious. Other things about these new guys, you can't measure things. Well, dabigatran, if they have no effect on the PTT, they didn't take it. It always makes the PTT abnormal. But you can't use it to tell how much. It's just either normal or abnormal. If it's normal, they didn't take it. The kid got into the parent's stuff, the dabigatran's missing, the kid's got a normal PTT, nothing happened. But other than that, testing has no use for any of these drugs, zero. That's its advantage, but also you can't monitor where they are. What else? So at the end, there's a couple of articles which say what are the advantages of these things, particularly PCC. But I want to tell you about an article that's not in here. It's by Ryan Radecki, who is a really smart guy, emergency physician who has a blog. I don't remember the name of it, but it's really interesting. And he's a muckraker. And he got this article in the Annals of Internal Medicine. I have no idea. He's a young guy. I have no idea how he got it in, because it looks at these novel anticoagulants. And it trashes them, which is amazing that they published it. It's an editorial in the Annals of Internal Medicine, one of the big journals in the world, from July 2011. And he said, you know, these drugs are selling billions of dollars, but dabigatran, nobody should use because it increases cardiovascular risk. There are two huge studies, including the manufacturer-sponsored RELY study, which say it increases cardiovascular risk in a clinically significant way, and not surrogate markers, real outcomes, death and heart attacks and stuff like that. And I think that got a lot of publicity. Now, I don't know if that's affecting practice. Is dabigatran still being used a lot? What's the real name for dabigatran, the fake name? Pradaxa. Is it being used a lot? I thought it was going to go away, because this was big news, really increased. If that's what you're supposed to use it for, is prevent cardiac events, it was increasing them in the manufacturer study. What?
What type of events? Ischemic events?
Ischemic events. So dabigatran, that's not so good. And by the way, studies looking at how it actually works in practice are much worse outcomes than in the manufacturer studies. And then he said rivaroxaban has a black spot warning because if you try to stop it, you get increased venous thromboembolism at a very high rate, like with clopidogrel. One of the big problems with clopidogrel is you can't stop it. And then how about apixaban? Well, it was approved for I forget which indication, and the study here will tell you it's some VT indication, and it's safe and effective and great, except the manufacturer also submitted a request to get it approved for the treatment of MI, and it was turned down because it didn't have any benefit, and it increased bleeding, or I misspoke. The benefit it had was overwhelmed by the increase in bleeding. So it was turned down. Now, I don't know if you know this, but when somebody submits a study to the FDA, if the study is positive, you all get to see it. But if the FDA turns it down, you don't get to see it, unless the manufacturer wants you to see it, which they don't. So what that means is that the FDA feels no responsibility to tell us if a drug that is already approved for one indication is harming people. Not only do they feel no responsibility to tell us, but this has been actually looked at. There's an actual quote in the BMJ about this. The FDA says that it's not allowed to tell us if the drug that is already being used is killing people because it's a trade secret. The FDA actually said this. It's a trade secret. It was based on a psych medicine that was being, they asked to approve for an entirely different indication, already being used in the public domain. Suicides, did it cause suicides in these patients? We can't tell you. So in that study that was apparently turned down, the reason it was turned down, apparently it wasn't safe, like in the studies that we've read. I don't know. Anyway, they're part of life, so you need to know about them. There is no good reversal agent. They're very expensive. Are they better? Are they safer? I don't know. I wouldn't bet on it, but and I suspect that in 10 years we'll be back to Coumadin, but
I think what's amazing is that if you look on TV, they have commercials throughout. They've got like Arnold Palmer or these big celebrities say, "Oh, the greatest thing in the world." But of course, patients even start asking for that.
of course. I said this the other day. You want to change doctor behavior, get patients to ask for something. The drug companies know that. So, more good news.
While you're on coagulation, could you comment on tranexamic acid in major trauma?
Tranexamic acid in major trauma. I heard somebody mention it before. The CRASH 2 study. Should I let you? You want to comment?
Well,
I'm pretty sure I'm going to say what you're going to say.
let's not believe it.
Okay, so the CRASH 2 study was this massive study done in the third world, almost entirely in the third world, where they found that this 2-cent drug, tranexamic acid, decreased bleeding deaths in major trauma. And it did it by, not by a huge amount, by a believable amount. It was a small difference, but it was a real difference and would be important if it was real. And the drug cost nothing, and it has been used in other circumstances, particularly in GYN, for years and years and years. So now it's sort of popular in guidelines and surgical guidelines and stuff like that. If you look at the study, though, which is a very large study, it was done in places that bear absolutely no resemblance to anything you do. So there are hospitals where not only they don't have an OR, they don't have oxygen, they don't have anesthesia, they don't have a room. You know, it's a lean-to hut. A friend of mine has pictures of some of the places where this is done, and it's out in the bush. It's out in very, very different circumstances. So does that mean it doesn't work? No. Does it mean we should be cautious about believing it? I think so. It's not clopidogrel. It's probably not killing people. It costs very, very little. So I wish it's true, but I don't think it's reasonable to assume it's true based on that study.
I thought Ian Rep had a good comment though on it when they talked about it being within the first hour. A lot of us work in hospitals that are, we're 1 hour from a major trauma center at our hospital.
Right.
And if things happen, 20 minutes from us, significant bleeding is going to be, a pretty big deal. What are your thoughts on that?
So again, if it were true, it's pretty much a win-win. It's not expensive, won't break the bank. It would be lovely if it is true. If it turns out it's not true, which I think there's a chance. I think there's a real chance it just isn't as good as that study said, and that it really doesn't improve outcomes because the study is the way it was done is so enormously different than the way what we would demand if we did a study, that I just don't know the answer. So I think in the interim, absent evidence that it's harmful, it's perfectly reasonable to do it. But I wouldn't be surprised if it turns out it doesn't work, and I wouldn't be shocked if it turns out that on balance it's a little more harmful than good, but I don't know.
So it's being researched and used a lot in our top trauma set in Canada, just to the guys that are measuring the clot formation and disintegration of massive blood loss. And now it's standard of care. They're quite convinced that 1,000 milligrams repeated.
Good. So they're looking at it in Canada at a very fancy trauma center, but the one thing you said that would give me pause is if you're measuring surrogate outcomes, what the clot size is, how much it is, that doesn't give me the answer I want to know, because what I want to know is, did it stop bleeding, but also did it kill somebody because of clotting? So there's the two things where you could easily overwhelm one versus the other. And how many times have you had, I know I've had, where my surgeons are very enthusiastic about something until we abandon it, all of us abandon it 2 years later. Like, for example, 1-to-1 ratios, which I'm pretty sure we're going to be abandoning very soon, even though every surgeon and trauma surgeon in the world said it's the best thing since sliced bread. So maybe, I'm not saying I know that it's not, but I'm just skeptical. I remain honorably skeptical. But maybe, and unlike where somebody's selling it to me at $1,000 a pill, you know, I hope it works.